Good morning all. I welcome everyone for this third day on the GAM course on biofluid mechanics, mathematical modeling and challenges. So Professor Yun she'll be continuing her lecture today. It's from 10 o'clock to 1 o'clock. Director Professor.
Hello, good morning everyone. We're going to look at different topics today. This is about multi-scale modeling of thrombosis and thrombolysis. So first we're going to have a very basic introduction of hemostasis and thrombosis. So I do not plan to give you an extensive introduction into the biochemistry involved because that's not the focus of this course. But we just have a very basic superficial introduction of the topics, enough for us to understand the need to build a model. I will then take you through the thrombosis model that has been developed in my group. And this is a hemodynamics-based thrombosis model. And then I show you the application of this model to simulate thrombus formation in aortic dissection, and also how we validated the model. And once we finish the topics on thrombosis, we'll move on to related but different topics on thrombolysis. And thrombolysis means that once the clot is formed in the blood vessel and it blocks the blood flow and impair the blood supply to the distal tissues, then medication will be required. So a thrombolytic agent could be introduced which interact with the components of the blood clots and then dissolve the clot. So we look at how that process can be modeled mathematically, and then I show you examples of modeling of thrombolysis in scenarios representing ischemic stroke. All right, so here is the very simplified way to look at hemostasis. So what is hemostasis? Well, that is a natural process that stops the bleeding, stop the body bleeding when we had an injury or maybe a minor injury. And so I use this schematic diagram, and this diagram can be found in this website because I think that this is just enough to understand the problem but not too complicated. So the process starts with vessel injury. So here that we have damaged blood vessels, so it's injury to the vessels, and these actually trigger the release of clotting factors. It can also trigger activation of platelets. So remember that in the first lecture we talked about the constituent, the species within the components within blood. And platelets, even though it only occupies up to like 4.5% of the blood cell volumes, is still an important, very important component, especially in its role in the clotting process. So the activated platelet will then stick together to form a sticky plug like this. And so the injured vessel also triggers some other responses. For example, vasoconstriction, which means the vessels start to contract, and that also help to limit blood flow. And then together with the formation of a sticky platelet plug, and these can temporarily stop bleeding. So this is part of the process. But because the injury triggers the release of clotting factors, and then these can set off a series of very complex biochemical reactions. Now, one of the key players in this process is called the thrombin. So thrombin is a very important enzyme, and the thrombin can convert fibrinogen, which is soluble in blood, to fibrin, which is non-soluble. So the fibrin will present like a fibrin strand, and they stick to the activated platelets. So with the fibrin strands stuck together with activated platelets, there is a relatively stable blood clot that is formed. And so this will will give the tissue time to repair and for wounds to heal. So this is a natural process, natural hemostasis process. Now, this process, the formation of blood clots, involves a very complex network of chemical, biochemical processes, and it also coupled with the transport mechanisms. But generally speaking, this involves these three stages. So the first stage is the platelet addition and activation. So we said earlier that an activation of platelet can be triggered by injury to vessel, and it can also be triggered by other factors, and that actually is relevant to flow, and this can be triggered by shear stress, for example. And the second stage is aggregation. So this is about the platelet to platelet addition and aggregation. Now this leads to the formation of the primary platelet plugs, and this is known as the primary hemostasis. So the cartoon in the middle. And so this temporarily seals injured section, but it's not very stable. And it requires this very complex coagulation cascade. So this means this is a coagulation process, and it's a secondary hemostasis, and this involves three major pathways. So this pathway are actually very well established. So these are known as extrinsic, intrinsic, and common pathways. And amazingly, if you look at all the species involved in this coagulation cascade and all the chemical reactions, you're talking about nearly almost 100 species involved, and that involves more than 100 chemical reactions. So imagine that just solving the coagulation cascade and all the biochemical reactions involved itself is a very complex process. And when we talk about thrombosis, so obviously this is the formation of clot, but these terms usually refer to abnormal formation of blood clots within a blood vessel. So this is undesirable clot. In some cases, hemostasis is desirable process. It's a natural process. But the abnormal formation blood clot is undesirable, and then so that would require treatment. Well, if we look at the causes of thrombus formation, and again, this is interesting established theory known as the virtuous triad. So the virtuous triad says that there are three major factors influencing the formation of other causes of thrombus formation. One is about the constituents of blood, and this is related to the hypercoagulability of the blood. And the vessel injuries and the endothelial injury, because this triggers the release of the clotting factors and also trigger the activation of platelets. And then the third one, which is also very important, is the altered flow condition. So understanding blood flow is also very important in our understanding and therefore modeling of the thrombus formation. So now, where did we start? What was our motivation of building a thrombus model? Well, this was actually the question. So we started building this model like 10 years ago with a PhD student. And so at the time that the problem we had in mind, we were interested in, is aortic dissection. So I showed you some simulated flow patterns in aortic dissection. So here we have another diagram. So this is a figure taken from a paper published in New England Journal of Medicine. And this is a prominent journal in medicine, in the field of medicine. So this illustrates very well aortic dissection. So here you have the main aorta, and I mentioned yesterday that aortic dissection starts with a tear in the inner layer of the aortic wall. So imagine here that there is a tear that is formed, and then blood will flow through the tears and then splitting the wall layers and creating a secondary channel. And so this is the secondary channel sitting in parallel to the primary aorta, which is the true lumen. This is known as the false lumen. So this can actually propagate and run all the way along the aorta. And sometimes, in some of the figures we saw yesterday, that the false lumen could be larger than the true lumen. So when a patient develops aortic dissection, there's certain things could happen. And interestingly, in some patients, that the disease can heal. And the way that it heals is like shown on the right. So that the thrombus is actually formed within the false lumen. And then if the false lumen is thrombosed, it means that these tears get blocked. So there's no new blood coming into the false lumen, and then the flow will primarily be channeled through the true lumen. So this is a natural sort of healed process, it's stable aortic dissection. Obviously, this process is desirable. So doctor would wish that the patient's false lumen will be thrombosed, and then so that the condition will remain stable and give time for further treatment. But the thrombus doesn't always form in a false lumen, and sometimes there's no thrombus formation in the false lumen, and in some cases that there is a partial thrombosis in the false lumen. So for instance here, that it only covers part of the false lumen, whereas the majority of the false lumen is still open and still patent. So then the question is, what dictates the thrombus formation? And then is it related to fluid flow? And can we model this process? And there's medical evidence that the partial thrombosis, like this one in the middle case, is a significant predictor of a higher mortality risk. So in other words, if a patient develops a partial thrombosis in the false lumen, then at a much higher risk for death and other more devastating events. Whereas complete thrombosis favors patient recovery through false lumen occlusion. So the question that we had, and the clinician would be very keen to find answer to, is can we predict false lumen thrombosis for a given patient? So this FLT stands for false lumen thrombosis. So that's where we started, and the motivation for us to try to develop a mathematical model that can predict the formation of thrombus within the false lumen of aortic dissection. So we're fairly specific at the start. We were not trying to build a generic model to simulate clot formation in any part of the body, but specifically to address this question. Right, so having had a rough sort of understanding about the hemostasis process and also the thrombosis process, we obviously realize there are lots of challenges in building such a model. So first, this is a multi-scale process because involvement of cells like platelets and activation of platelet, aggregation of platelets, etc. And then also it's a multi-species process. It has a large number of species involved. It is a multi-phase because the platelets are the cells, and the red blood cells are also involved. They're entrapped inside the clots. So it has the fluid phase, it has a solid cellular phase. I mentioned earlier that the coagulation cascade involves tens of species, could be up to 100 species, and more than 100 chemical reactions. And on top of that, we also deal with the complex geometry, which is relevant to the aortic dissection, right? So the geometry of the aortic dissection is very complex. It's not a normal aorta. It has holes, has tears, and true and false lumen, etc. And then the formation of a clot, it is a long period. It could take days or even months or maybe years for thrombus to grow. Right, so these are the challenges. Then once you have these challenges and you also have a question in mind, so the next is to try to find your strategy. So how best to deal with and solve this problem. So our strategy was to build a phenomenological model. So instead of modeling the more than 100 of all the biochemical reactions involved and couple that with the transport and the flow, It's not impossible, but it's extremely challenging task. You will probably need a lot of resources and computational time to solve the problem. So we're trying to avoid directly simulating all these complex chains of biochemical reactions. We focus on the key players within this clot formation process. And then, so we simulate the thrombus formation that grows based on the hemodynamic parameters. And in fact, this approach is well-founded and based on the study published in Nature Medicine. So if you read this paper, and they've done the experimental studies and trying to relate the role of flow, blood flow, with thrombus formation. So on the basis of that, we decided to adopt this approach, and so that we will simulate platelet addition, but this is driven or triggered by flow in the region of low shear. And we model the thrombus growth, and that's driven by the local hemodynamics. So this is our approach, and then our assumptions. So the assumptions that we made before we built the model was that the probability of thrombosis is determined by local hemodynamics. So when we talk about local hemodynamics, so we first, of course, we have to solve the flow using the technology that I demonstrated yesterday. So we model the flow, and then once you have fully resolved the flow field, you'll be able to evaluate local shear, and then you can also find the fluid residence time, and then distribution of the platelets. So the distribution of platelets, and these need to be solved by coupling the transport equations together with the flow equations. So when we talk about platelets, because we know that the platelets can be present in different status. So you have resting platelets. So RP stands for resting platelets, and then AP stands for activated platelets. So this is after activation. A resting platelet can be activated to become activated platelets. And then this BP stands for bound platelets. And these are the activated platelets that are bound to fibrin. So once they're bound to fibrin, they form clots. So in other words, when you see BP, and this is a surrogate of clot, because this is already bound with the fibrin strands. And the whole model is built on the concept that the low shear thrombotic pathway is dominant. And the concentration of coagulation factors, well, there are multiple species involved, but we kind of find a cluster of those. So instead of tracing each individual species with specific chemical structure, we cluster them together. So there are a few of those that are most important in the clotting process. We cluster them together and then call them a coagulation factor. And then, so we assume that these are high in regions of flow stagnation and recirculation. So these are the areas where there's a flow reversal and recirculation. And in these areas is characterized by long residence time. So the residence time can be obtained as part of the solution. The other assumption is that the initial concentration of activated platelets is non-zero. Well, this is valid because as we know that when there is a vessel injury or injury to the endothelium, then it triggers activation of platelets, right? So when we think about aortic dissection, it is an injury to the arterial wall because it involves the tear and then the splitting of the layers. So that means in the system, there is the presence of activated platelets already, so the initial condition is non-zero. Right, so some of the equations, so I'm not going to include the flow equations we already dealt with previously. So the Navier-Stokes equations still applies, but these we just look at the additional equation that we had to introduce in order to couple the process of simulation of clot formation with the flow. So there's one equation that, because we need to evaluate the residence time. Well, the residence time here, we just assuming that we have modeled as a passive tracer in the blood. So you put into this transport equation. So you probably recognize this transport equation. You have the convection and diffusion terms, and it's normalized so that you solve for this equation, and then you get the relative residence time distribution. And then we model the platelets. So we model these resting platelets, and this is the original states of the platelets. And then once it's activated, it creates an activated platelet, AP. And then these are modeled using convection diffusion reaction equations. So here we recognize that you have the convective term, you have the diffusion term, and you also have a source term. So the source term actually accounts for the relevant reactions. So here that the source term consider two reactions in our model. One reaction relates to the further activation of the resting platelets by the activated platelet. So there is actually a feedback mechanisms here, so that once the platelets are activated, the activated platelet can further trigger activation of the resting platelet. So all of these need to be taken into account. On the other hand, the resting platelet can also be activated by thrombin exposure. So the thrombin, as said earlier, is one of the key enzymes in clot formation. So that needs to be reflected in this model. Now, so even though that the thrombin is very important, we not model the thrombin directly, and so this is represented mathematically by setting a thrombin concentration as being high in regions of very high normalized relative residence time. So a very detailed description of these all the mathematical equations, I think there are more, which will come in the next slides. And these were described in our first paper. It was the model was developed by my PhD student Claudia Mincini. So these are some additional equations. We also need to model coagulants. So the coagulants, and again, we use these convection diffusion reaction equations, and then with the reactions considered the consumption terms to prevent the accumulation of coagulants in high shear regions. So all these mechanisms are based on our understanding of the influence of flow on clot formation. So then there is the equation for bound platelets. So I said earlier that the bound platelets actually is a surrogate of the clot. So once the platelets bound to fibrin strands, and they form a stable clot. So this is involves a reaction equation, and that mathematically is described by using a switch function here. So you can alternate the species to coagulant, to relative residence time, and bound platelets. And eventually that the clot is treated as a porous medium. And so the porosity it actually is not a constant. It varies, depends on the clot formation. So the more bound platelet there is, then the less porous that the clot becomes. Right, so this is the flow chart for the thrombosis model. So you start modeling the flow, and once you have resolved the flow field, you work out the shear stress and identify a low shear region. And then in the low shear region, that you trigger the production and diffusion of a coagulant. And then you set some threshold. If the shear is sufficiently low, if the relative residence time is sufficiently high, and then it can trigger some further events. So these trigger the production of bound platelets, which is the formation of the clot. And once the clot is formed, it changes the porosity within the porous medium, which represent the clot, and then that obviously would increase the resistance to flow. And then all of these has been coded and programmed into ANSYS CFX. So I think on the right, these I may be able to, let's see. Yes, I can play this. Oops. Right, so we start off with idealized geometry. So this is idealized LT dissection with the arch, and then you have two channels. One is the true lumen, the other one is the false lumen. And there is a connection between the true lumen and false lumen through a tear at the top, and then there could be a tear at the bottom. So the tear at the top is usually called a primary entry tear, and this is a re-entry tear. So in other words, the one at the top, that the flow actually flows through the tears to enter into the false lumen, it goes down, and then if there is a re-entry tear further downstream, then the flow can actually return to the true lumen through the re-entry tears. And so the model allows us to simulate how the thrombus is formed in such a geometry. So I'll take you through these a few variations of what you can play with an idealized model before you apply your model to realistic scenarios. So this will just give you some understanding about how the various factors might influence the flow and the thrombus formation. So here we have a more detailed diagram to show what the geometry is like. So this is a flap. So the flap is actually the septum that separates the true lumen from the false lumen. And then you can see that if you just look at the flap, we have, in this idealized model, we have two holes. So these are the two tears. This is the primary entry tear. This is the re-entry tears. The re-entry tear is somewhere here. Primary entry tear is further up here. And from the flow mechanics point of view, it's quite easy to understand that if you have a primary entry tear here, then part of the flow will divert into the false lumen. So you can see that some of the flow have exited the true lumen through the primary entry tears and entered into the false lumen. And then this time point, it just goes. I think this is a model that this is a model that does not have a. I think there are three models here. This model does not have a re-entry tear. So this model only has one tear. So you can do geometric variations with idealized model. Now if you only have an entry tear, then the blood goes in, but it can't go anywhere else, right? It can't exit. So there's a small amount of blood enter into these tears. And if you have a re-entry tears, if the re-entry tear is somewhere here, and you can see you have flow comes in, and then you have a flow leaves the false lumen going back to the true lumen. And then if you have the re-entry tear further downstream, and then you have the flow going through all of the, along the false lumen. So it gives you a different flow pattern, and that also gives you a different shear stress distributions, and therefore different thrombus pattern. So now what we're looking at here are the different models. I think you can see that there is only one tear, the primary tear, which is at the top. And you can see that, so the blue region corresponds to the region where the blood flows, so the lumen area. And the red is the false lumen. And then it comes, so you can see that in this case, you have flow enters into the false lumen, and then it propagates, but then it does not leave. It stays in there. And then, but over time, a thrombus can actually form. So these are, I think these are the thrombus that formed over time. So these were simulated over a long period of times. And eventually, because you have no exit, so the blood will clot in the false lumen, and so you only have a little bit of entry left. And this case, I think that's the different scenarios. In this case, you don't have a primary entry tear, you have a distal tear. So the tear is somewhere in the bottom, which means that the flow, a small amount of flow can actually enter the false lumen through the bottom. And similarly, that over time, the false lumen will be thrombosed. But if you have two tears, you have entry tear, you have a re-entry tears, then the scenario is different. So you have flow entering it, and you can see that because there is another re-entry here, that the flow will try to find its way to come back to this channel. But the flow towards the end, the bottom end, the top end, and also the bottom end become very, very slow and stagnant. So over time that thrombus will form at the top and bottom end, but then this middle part is still patent with the flow coming in through the entry tear and leaves through the re-entry tear. And this one is another scenario. So I think in this case, you also have two tears, one at the top, one at the bottom. Only difference is that the re-entry tears is further downstream. Re-entry tears over here, so that the false lumen is patent for most of the region, except the very top, which gets thrombosed. So the red part corresponds to the thrombus that was formed over time. And then there is a little bit of the bottom part that gets thrombosed, but the majority of the false lumen is still open, that allows the flow. So we had some basic understanding about how the geometry and flow pattern might affect thrombus formation in idealized ALT dissection geometry. So now we're ready to apply this to more realistic scenarios like patient geometries. So I went through yesterday that the steps that we follow to build a realistic model, and that include acquire images from patient. And these shows the CT scan of a patient with dissection. So you have multiple slices, usually a fairly large number of slices to cover the entire aorta. So for each of these, we perform image processing to segment the vessel lumen, and then one at a time, and then you can stack these together in the along the vessel axis, and then that will give you a three-dimensional reconstruction. You then consider applying some realistic boundary conditions, for example, a flow waveform or velocity profiles at the inlet, and a pressure-based boundary condition and at the outlets, which is realized through a three-element Windcastle model that we discussed yesterday. So here is a representative geometry. So initially, our model, we're trying to keep the model relatively simplified, so we did not include the arch branches. We just modeled the aorta, including the true lumen and the false lumen. And then we solved all the equations that I described earlier. So this is, and then the model can predict where the thrombus is formed. So we're going to look at the model predictions for different patient cases and how we validated the model. And if you want to read further, we have published some of our cases and results and validations in this paper, also by Claudia. So the first example we look at is a patient with ALT dissection is medically treated, so they did not receive surgical treatment, and the patient was followed up over a period of times. And then during that monitoring period, that the patient was found to have developed spontaneous false lumen thrombosis. So in other words, their false lumen actually thrombosed over time, which is obviously desirable, so the dissection is stable. And so here we see these are not models, these are the true geometry reconstructed from CT scans. So this is initially what the patient dissection looked like. So they have, this is the main aorta, and you have a true lumen. You can see that the true lumen is actually compressed by this false lumen. The false lumen is actually quite big. And initially the false lumen starts from here, and then it runs all the way along the true lumen further downstream. And so this is the initial presentation, and then after some time, that you can see that the shape has changed. And the reason that the false lumen shape has changed is because this top part, the thrombus is formed. And that's why the region that is available, the lumen that is open to the blood flow, is smaller. The volume is smaller, so that the shape is like this. And further down the line, 6 months later, that this top part also gets thrombosed. The thrombus filled this part, and then so when you just reconstruct the lumen, and the false lumen look like this. So it looks like this part of it disappeared, and then another scan later on shows that well, this part has kind of stabilized. There's no further thrombus formation. But somewhere over here, you can see the shape has changed if you compare this geometry with this geometry, and which means that some thrombus is formed over here. So it's interesting that this is what the CT scan shows. And a good test of our model is, can our model actually reproduce what it can be seen on the patient through CT scans? So this is the model that we build. So we start with the initial geometry at T1. And so you can see the connection here, and you start with the initial false lumen like this. And then you simulate the thrombus formation over time. At T2, you start to see thrombus formed at the top, which agrees pretty well. And if you run it for a longer period of times, and then this top part gets thrombosed, exactly as observed in the patient, like here. And then if you run it, you find that the thrombus also, the simulation also showed that the thrombus formed somewhere here, which agreed quite well with observation at 6 months on the patient. I think this one is not animation. Next one probably has animation. So these early stages, thrombus initially formed in areas of high residence time at the top of the false lumen, right here. I think this is animation, if I can play, and let me try. So you can see the simulated clot formation. It starts from the top, and it gradually fills the top. And the thrombus does not grow continuously, because thrombus formation requires a certain condition to be met. So once those conditions are met, then thrombus start to form and grow. But when the flow field changes and shear stress residence time changes, the condition for thrombus formation do not exist, and therefore the thrombus formation will stop. So the model can actually simulate that process quite well. Let me see what's next here. Okay, so that's how it correlates with the actual observed thrombus formation. And then let's move on to the next time point. It's still the same patient, and to see the later stages. So we simulated the formation of the thrombus at the top of the false lumen pretty well. So can we simulate the thrombus formation around a second tear? This is at later stage. So right, these are the snapshots. You can see that at this point that there is no thrombus formed in here, but then later on you can see at this point that the thrombus already formed, and then further formed over here. So if you compare these, the predicted geometry of the lumen, and that actually agreed quite well with the CT scan. This is reconstructed based on the CT scan. So from this case, what we have learned by this simulation is that there is a strong correlation between the tear configuration, so where the tear is and how big the tear is, and these influence the hemodynamics and therefore influence the shear stress, shear rate, and the residence time, etc., because all of these parameters influence the growth and the formation of thrombus. So also we show that there is a good qualitative. We have not made quantitative agreement, quantitative comparisons just yet. I'll show you quantitative comparisons later on. But at this stage, it's just to visualize, to see qualitatively whether we can predict the trend as observed in a patient. I think this one shows, this is the animation that shows you, so this is the simulation. I think this is simulation. If you just look at, pay attention to this part, on the right, so this is the actual geometry based on the CT scans, and the left is the simulated geometry, and you can see how this dent on the surface is actually formed because of the thrombus formation. It happens quite slowly, I think. Does it show anything? No. Oops, sorry. Somehow that animation doesn't play, but it does show that in the simulation that the surface slowly dents in, and because the thrombus formed, and that agreed pretty well with the observation. Now, we move on to another patient, and in this patient they found partial thrombosis in the false lumen. As we said earlier, that there's medical evidence showing that the partial thrombosis correlates strongly with further complications, so it's undesirable. So we wanted to understand in this case whether we can actually predict partial thrombosis or not. So we have a patient geometry over here, and I think this shows at this section, that's where the thrombus is found to be formed. So this is the CT scan at 3 months follow-up of this patient, which shows partial thrombosis. So this dark region is the thrombus, where the thrombus is, and this bright region, these are the lumens. So you can see that there are two bright regions separated by these what we call flap. So you have the true lumen, which is heavily compressed by the false lumen. So the false lumen occupies a much larger area than the true lumen. And then here's the thrombus that was formed. And then if you look at later on, this is a 9 months follow-up. So at 9 months follow-up, you can see that at the same location, the thrombus has grown. So a larger part of the false lumen has thrombosed, but the false lumen is still patent. So there is even though there is a reduced cross-section area for the false lumen. So with these CT scans, and we wanted to see, can we actually model and reproduce what happened in this case? So this shows the simulation results at this cross-section, which are aligned with these CT scans. And this is the true lumen where there is blood flow. So obviously thrombus does not form in the true lumen. And then this is the false lumen. I think the colors actually correspond to the flow. So we just look at the flow pattern. So we can see that initially there is a slow, so the blue region corresponds to low velocity or flow stagnation. And over time, we can see that this region expand, and this region expand. You can see the orientation and the location of this flow stagnation region actually agree pretty well with the region where the thrombus is formed. And if you run the simulation further as the thrombus grow, that this region continue to expand, and then over here that you have this blue region that correspond pretty well to this. Well, if you look in detail, the shape or the area, there might be difference, but in terms of the qualitative comparison, I think the agreement, the trend is predicted very well. There is only one thing that I forgot to mention, is that it's the time scale. So in our simulation, I mentioned earlier that the thrombus formation actually takes a long period of times in comparison to the time scale that we usually talk about for blood flow through a cardiac cycle, because a typical cardiac cycle is like 1 second or even less than 1 second. But the thrombus formation takes over days, months, or could be even years. So how do we simulate? Obviously you cannot run your CFD simulation for blood flow through aorta for like many years, and that could take enormous amount of computational time. And so in this process, the trick is that we have artificially accelerated the clotting process. So the time that you see here, 3.25 seconds and to 21 point some second, this does not have a real physical meaning. It does not necessarily mean that the clot can actually form within these short period of times in reality. However, they can actually be scaled to the real time, and that's something that has not been resolved yet. And now let's try to continue to look at the applicability of this model and look at whether we can predict thrombus formation after a procedure called TIVA. So this is a thoracic endovascular aortic repair of aortic dissection patient by putting a stent graft. So putting the stent graft into a dissected aorta. So this is for the same patient. This is the pre-stenting geometry. You can see the tear here, and then you can see a very large false lumen. And after the procedure for the same patient, after the stent is put in, and you can see that the geometry is fairly normalized at least in the descending aorta over here, even though if you look at the distal region, there is still presence of some false lumen, a small part of the false lumen remaining. So the purpose of putting a stent is to cover this tear, and if the primary tear is covered, there's no blood flowing into the false lumen through the primary tears, and then that promotes flow stagnation inside the false lumen, and then thrombus will form. So the patient will heal. So that's the idea. And so we wanted to see whether the model can actually predict the thrombus formation after TIVA. So this is, let me see if this is animation. This is not animation, so yeah. So I think to be safe, I always have some snapshots in case the animation does not play. So these are the snapshots of the simulation results captured different times. This is at the initial time. You can see that there is a bit of a, because after the procedure, the false lumen has been compressed. It's pushed back, so you have a true lumen running through. But it doesn't, because the false lumen is very, very long. You can't have a stent graft that covers entire false lumen because there is issues about, you have to make sure that there is a blood supply to the other part of the body in the chest and also in this region as well. So because the stent is covered by a fabric, by putting a covered stent graft inside, it partially blocks the blood supply or blood perfusion to the other smaller branches that are necessary in the body. So the length of the stent graft is actually limited to a certain extent. So part of the false lumen still remains. So we wanted to see in this case, even if that part of the false lumen remains, and after the procedure, can thrombus form in the false lumen over time? So this is a simulation. Initially, you have the false lumen here, and then you can see that after a while, that the thrombus is starting to form, and you can see this false lumen started to disappear. At this time point, that the false lumen has almost completely disappeared after that. So the prediction says that the procedure is successful, the false lumen is completely thrombosed over time after the procedure. And I think this one is actually the animation, if I can play, I can't be sure. I don't know why the animation does not play. It played on my computer. But maybe there is a change of the system over here. Just try again. Oops, yes, you can see, right? Yeah. So this is the prediction over time, how these have changed. Right, so that's the case with complete thrombosis. Now, we also have patient who had this TIVA procedure, but their false lumen still remains. It's incomplete false lumen thrombosis after TIVA. So we wanted to see if our model can predict that scenarios as well. So it's just trying different scenarios to test the applicability of the model and whether it can simulate the real scenario. So this is pre-TIVA geometry. You have a dissection tear, you have false lumen, which runs all the way here, and in fact, in this case, You can see the true lumen, how narrow the true lumen can be. This is very thin true lumen over here. There is multiple tears connected between the true lumen and the false lumen. Eventually, these two lumen merges into in the abdominal aorta. Right. So this patient is treated and with the stent graft put inside, and because it's very long, so the stent graft only covered the primary entry tears and maybe one of the middle tears as well. And then, but the part of the false lumen still remains, and this is 2 months after the procedure, after the CT scans. But you can see that there is still a connection between the true lumen and the false lumen. This is through these reentry tears. And then later on, 4 years later, in this patient, you find that this false lumen still remains. So this false lumen is not completely thrombosed. This is an incomplete thrombosis case. So we wanted to test our model to see if we can simulate the same, produce the same scenarios. So this is the snapshots of the simulation taken at different time points. So starting with the initial geometry, and then after the simulation, you can see that the top of the false lumen started to thrombose, so that the false lumen volume started to reduce. And then after some further simulations, that this part of the false lumen disappeared, and but the distal false lumen still remains because there is a connection, there is a tear between true and false lumen. And as you run through the simulation, and this part actually remains continuously because of the communication between true and false lumen, it actually never disappears. So this, if you compare these with the CT scans 4 years after the surgery, there are obviously lots of similarities between the shape, but you probably spotted that the prediction is slightly different from the reality in that it has these little peak pointed edge of the true lumen, the false lumen is still there, and that is not thrombosed. So I'll come back to that point later after the model has been further modified. But generally speaking, that it performed reasonably well, and it can predict the false lumen thrombosis even for this fairly long period of time. I think this one is the animation. It just basically shows the evolution of the thrombus formation as predicted. So the model performed such that after this time point, the thrombus will stop forming. So even if you run more than like 40 seconds, if you run it up to 100 seconds, it still remains the same because the conditions for thrombus formation are no longer satisfied. Right, so then we showed that it can simulate thrombus formation in a medically treated patient. We can show that the model can predict complete thrombosis, partial thrombosis in patient after treatment. So we found another patient which is medically treated, has not been treated with surgical procedures. And in this patient, there is no false lumen thrombosis. Obviously, this patient will be treated, but before that, we wanted to test our model. There is no thrombus formation in this case. What we'll get from our model? So in fact, in this case, I think no thrombus formation. So we simulated the flow. This is the flow field. And so because there is a tear over here, so you see high velocity jet coming through the tears, entering into the false lumen. This is what the false lumen flow look like. And then it runs down. I think there is the true lumen, false lumen merges somewhere down there. In this case, well, there is a region of a slow flow and low shear. However, that the large distance between the tears, between the primary, and there is a reentry tear over here, allows this kind of streamlined flow. And then as a result, the shear stress is never low enough and the residence time is never large enough to allow thrombus to form. So our model actually predicted no thrombus formation in this case. So that also agrees with the observation. And in fact, we've tested our model on multiple cases. So we're part of the ABSORB trial, which is European-run trial for LT dissection patients. We had more than 20 medically treated patients and also TIVA-treated patients with follow-ups. So follow-ups allows us to validate the model. So we have one complete thrombosis case that I showed you, and we had 8 partial thrombosis cases. I've showed you one of the examples. We have the medical treated patient, one with complete thrombosis, and a partial thrombosis and no thrombus. So I've showed some of these examples to see how well the simulation agree with the actual observations. And some further model validation. So you probably see that in all the models that I showed you previously, we made some simplification in the model by deleting these arch branch vessels, and there are also some other branches which are quite important, because initially we wanted to keep the geometry as simplified as possible without losing. Obviously you have to model the dissection. The dissected aorta has to be included, but the other branches we had trimmed them off and just to focus on the thrombus formation. But then after we have validated the model, we built some confidence in the model performance and prediction. Then we started to make the model more realistic by adding the actual branches and all the major branches being included, and using Windcastle physiologically relevant boundary conditions at the outlet. And so this is the predicted flow field. So you have, this is the fourth lumen in this case, and then you have one tear. So in this particular patient, that the tear is quite low, and then there are some additional entry tears over there. So, and this is the predicted flow pattern shear stress based on the initial CT scans after this TIVA procedure. So you can see the shear stress pattern. This is the shear stress pattern over here. And just to note that in the fourth lumen, there's a region of low shear stress. So this is the area where thrombus might form. And this is another patient where the prediction, right, so this patient that start off with a false lumen that looks like this shape, and then over time, so prediction shows that this false lumen started to thrombose, and then so the volume of the false lumen start to reduce over time until it's reduced to this volume, and then it stopped. So thrombus will stop form after this time point. And this compared with the follow-up, 1 year follow-up like this. Even though that the shape does not match exactly what is seen on the CT, but the location and the trend has been predicted quite well. And similarly, this is for another patient, after including all these branches. And then we found that, so this is the initial false lumen, and then it shows that the thrombus formed in the false lumen and start to reduce, and then until it disappeared almost completely. And so this is a 1 year follow-up. Now, if you compare the 1 year follow-up, this is actually quite similar to this prediction at this time point. And then if you look at the 2 year follow-up, and this part of the false lumen is also thrombosed, and that's also predicted at later time when this part of the false lumen has been thrombosed. So this one agreed quite well with the 2 year follow-up. So even though that the time scale in our model is not physiologically realistic, it's not directly relevant to the real time, but there are some correspondence. So in other words, our model can predict whether thrombus form or not, but it cannot predict exactly how long it will take. It can't say, the thrombus will form after 3 months or after a year, and that's beyond our control. But we can tell that the thrombus will form or will not form. Okay, so we're going to continue with where we left. So here we have idealized geometry of aorta. We wanted to, so using the model, we wanted to understand whether there are any geometric factors that are associated with false lumen thrombus formation. So, well, I think the motivation behind this is that if we can identify any geometric or morphological factors that can predict false lumen thrombosis, then it would become easier in practice, because the geometric parameters can be measured directly from CT scans. And then if any one of these features, for example, the distance between the tears or the size of the entry tear or location of the entry tear, if any one of these is a strong predictor of false lumen thrombosis, then we don't have to predict the thrombus formation. We can just look for these, measure these parameters, and then that will give you an indication as to whether the thrombus can form or not. So we use our model to examine these features, and I think I'll just show you a few examples of these. So we start with idealized model. So the one that you look on the left, top left side. So all of these models have got two tears. One is the top, one is the bottom, and they differ. So these models differ from. So the differences is the tear to top distance, right? So let's see. This is the tear, and reducing the tear to top distance. So you can see that from pH1 and all the way to pH3, that the tear becomes closer to the top of the arch, right? So this one is very close, it's the highest. This one is in the, sorry, I just realized that you can't see my cursor there. So this one is the highest, this one is in the middle, and this tear is further low. So we're talking about the distance between this tear and the top of the arch. And to see how this parameter affect the flow pattern. So we're looking at the shear stress distribution here, because the shear stress has direct relevance to thrombus formation. Right, we can see that as you increase the, or as you reduce the distance between the tear and the top of the arch, that the shear stress, this region of low shear stress reduces. So initially you have this much, and then as you bring this up, then this disappears, and if it's further up, then it doesn't, there is no region of low shear stress. And then what that means is that it is more unlikely for thrombus to form in the top of the false lumen if the primary tear is very close to the top. And likewise, I think each one of these changed one of those geometry. So the one on the right is to increase the entry tear diameter. So, so this one, so you start with the small diameters all at the same location, but then you gradually increase the diameter, and to see how these would affect shear stress distributions inside the false lumen. And of course, as you increase that, then you have areas, sorry, this is the, which one is the largest? I can't remember which way it goes. So you have, obviously that the size has an effect on the size of the high shear stress and the size of the low shear stress. And you can see that in this case that the low shear stress region grow as you increase the entry tear size. So all these were obtained by keeping the rest of the geometry the same. So here you can fix the tears and then reduce the curvature ratio, and to see how the curvature might affect. And it looks like that the curvature does not have a significant effect on shear stress distributions at the top of the false lumen. And this is to reduce the distance between the tears, and that means you keep the top tear the same, and then you move the distal tears up and down a little bit, and that obviously affected the region of the shear stress inside the false lumen. But as far as the top region is concerned, it changed a little bit, so from here to there. So anyway, this is just the numerical experiment, and And this is the advantage of having a computational model, because you can design your numerical experiment. So you can have a list of the parameters you're interested in, and then you can run numerous simulations trying to find the trend and to see which parameter is play a most important role. Or you can do a proper sensitivity analysis as well with all the variables. So this is predicted pressure. So you can obviously look at pressure distributions. So I'm not going to go through that. And there is one parameter that we found that could be quite interesting and might affect false lumen thrombosis is what is known as tear to vessel component. So this term was actually proposed by my student Claudia. So she just named it as a tear to vessel component. What she actually meant is that if you have a zoomed in picture of this region and you have a tear, you can see that there is a tear that communicates true lumen and the false lumen. But at the same time, so this is a zoomed in view, at the same time you also have a side branch, so a vessel. So this is what she called the tear to vessel component. And this tear is very close to the this vessel location where the branching point is. So then she found that this could affect the probability of false lumen thrombosis, and so then she created a different model. So this is a real geometry, and this is artificially created model by moving this tear further up. So if it's too close to the vessel, then in this artificial geometry she created, she kind of sealed this tear, and then but created the tear further up and away from these side branches, and to see how this might affect the thrombus formation. So she did some prediction and comparisons and looking at shear stress. So obviously you can see the differences in flow patterns when you so this is with the tear moved further up, and then you have a flow. Obviously you created a flow from here, and then there is a recirculation, and then before the exit through the vessel. And if you had a tear which is very close to the branching point, then the flow that exits or leaves through the tears will go straight into the vessel. So there's no recirculation. But here there is a region of flow. And then I think she also compared, so this corresponds to different time point of the at the cycle of interest. Yeah, so this is just to look at from the fluid mechanics point of view and how the flow pattern evolved. And the same comparison between the real model and artificially created model in terms of the shear stress, which is of interest. So you can see that the false lumen shear stress similar but not in this region. And in this region, when the vessel is directly opposite the tear and you have this high shear region, fairly localized, but if the tear is further up, then there is a jet flow coming through the tears, and the wall that is opposite to the tears has a high shear stress, and then there is a low shear stress in between, and then followed by the rest. So it does create a difference, and it causes difference in the pressure as well. So that's going to have a consequence, obviously, on the thrombus formation. So just to have a very brief summary of the work that thrombosis model that I presented so far, and you see that this patient-specific prediction of false lumen thrombosis is possible for both group of patients, whether they're medically treated or surgically treated patients. And it shows that the model can predict the correct outcome in terms of whether thrombus forms, complete thrombosis, partial thrombosis, or no thrombosis. However, there are minor discrepancies in the exact shape and the volume of the thrombus, which means that if one wants to be perfect, if you wanted to have an exact or more close agreement with the experiment in terms of the shape and the size, then there is a further room for the model to be improved. And as I said earlier, that our model cannot predict the true time scale of thrombus growth. And the model can be used to identify anatomical and the stent graft related parameters or factors responsible for false lumen thrombosis. So this is quite useful because especially when it comes to the choice of the stent graft lengths. And so the model can actually help to optimize the stent graft length required for the given anatomy of a patient, and so that it can maximize the probability for false lumen thrombosis, which is the desired outcome of treatment. So it will require further modification, and perhaps from the thrombosis modeling side, one of the factors that has not been considered is the thrombus breakdown, because we modeled how the thrombus form and then thrombus grow. At a certain point that the thrombus will stop growing. But in reality, that the thrombus can also break down. So that breakdown mechanisms was not included in Claudia's model. And that's something that my current student the next student followed and rectified that problem. And the other one is obviously the incorporation of wall compliance. So especially in the dissection patient, when we look at the septum, the flap, which separates the true and the false lumen, it is not rigid. It depends on the stage of the disease. In the early stage of dissection, the flap is very flexible, is mobile. It can actually swings back and forth, and that's going to have an impact on flow distribution and shear stress as well. So this model assumed the flap to be rigid and LT wall to be rigid. So that is one of the assumptions that need to be addressed in the future. So just come to us, the focus today is on thrombosis and thrombolysis. So I'll just show you what has been done in terms of incorporating the thrombus breakdown in the model. So this is a cartoon. When the thrombus is formed, it's subject to shear stress. And in fact, the thrombus breakdown can happen mechanically, can also happen chemically. So in our body, we produce TCU plasminogen activator, which is the thrombolytic, natural thrombolytic agents. It can chemically break down some of the clots, and that's why a healthy person would not have issues of blood clots blocking your blood supply. So it only happens in pathological conditions. And mechanically, the high shear stress acting on the surface of the clot can also break it down. So the current student made a slight modification to the Claudius model by adding these mechanisms so that when the shear stress is across the threshold for a certain threshold, then it can cause a thrombus to break down. So there is a breakdown mechanism built in. So the only thing, the equation that was modified is the differential equation that governs the transport of bound platelets, which is the clots. So introduced a breakdown rate, and that is related to a shear stress threshold. So, and then the switching function is still the same. So by introducing these, we can see what differences that actually makes. So first, he validated the model. We're very fortunate that there is an experimental group. This is based in, published by Yang et al. So in this paper, the experimental group is based in Penn State University in the US. I visited them last year. So they have very well established experimental facilities to measure thrombus formation and also thrombolysis as well. So they used MR scanners to visualize thrombus formation in idealized geometry. So they created a backward-facing step, and which the geometry looks like this. So this is the actual model, and with a backward-facing step. So from the basic fluid mechanics, what we know is that if you have flow entering from here and leaves from there, now as the fluid passes through these backward-facing steps, because of the local sudden expansion, that there is likely to be flow recirculation just behind the step over here, right? So you have flow recirculation, and when you have flow recirculation, that shear stress is low, right? So that is likely, this is the location where the thrombus will form. And so they performed the experiment with two different blood. They used the human blood. They also used the animal blood, bovine blood. And then they monitored the thrombus formation behind the steps as a function of time, and then measured the length, the height, and the volume of that. And that gave us very valuable data to validate our computational model. So in terms of model, we obviously you're trying to replicate the experimental setup as closely as possible. So the geometry is identical to that. Flow condition identical to the experimental condition. And perhaps the only difference is that there is a choice of non-Newtonian model that, so we chose this model, and then we tuned the parameters to fit the human blood viscosities and the bovine blood viscosities. And then you have a boundary condition here, and because the model, the tube, is long enough, and so that it's fine to assume a zero static pressure at the outlet. So let's see what the simulation looked like. Let me see. Right, so this is the simulated thrombus formation using the original model that we have, and you can see that the thrombus obviously formed behind these steps. But you can see that there is overgrowth of the thrombus over these the steps and going backwards, right? Now, after the model that included the thrombus breakdown, and you can see that this problem has been rectified. So this is predicted with the latest modified model that it had avoided this overgrowth of the thrombus over this surface, which is not realistic. So that's how a subtle change in your model can modify the predicted outcome. Obviously, we made some further, more detailed comparisons. So here that we can see the experimental data. These data were taken from Yang et al. And they had two sets of data. The blue triangles correspond to, these are the bovine. Yeah, these are the bovine blood experiment. And the red are the humans. So we compared our human simulation results with their measurements. And now, so first one we compared is the thrombus length. And so in addition to compare with the experimental measurement, we also compared between our original model that I showed you earlier and this new model that included the shear-driven thrombus breakdown. So you can see that in terms of the length, actually, they all agree more or less the same. So there's not much difference between the two models. And there's small differences with the experimental measurements. This is the height of the thrombus. So this solid line is the prediction from the modified model. And this line is the prediction from the previous model. And again, one is slightly above, one is slightly below. So they're reasonably close. But if you look at the volume of the thrombus, and that's where the difference comes. So here are the measurements, experimental measurement, and this is the prediction made by the modified model, and this is the prediction made by the original model. So you can see that obviously there's a large difference in the predicted volume using the original model, and the modified model had improved these agreement with the experiment. Oops. Right, okay, that's fine. So if we look at the using the modified model to simulate one of the realistic ALT dissection, and remember that one of the model that I said earlier that I mentioned in the first hour that we're going to revisit, and this is that example. So we start off with this geometry at the initial time, and we use a modified model to predict the thrombus, false lumen thrombus formation. So this is the prediction at different time points. Initially, you can see that the top of the false lumen is thrombosed, so the false lumen volume is reduced compared to the initial time. At this time point, the false lumen, this part of the false lumen has completely thrombosed, disappeared, but there is still this false lumen remain. And then at the end of the simulation, when the thrombus stopped growing, that this is what the geometry that is left. Now, compared with the ground truth, which is based on the CT scans. Now, the CT scan also showed that this top of the false lumen had completely thrombosed, but this bottom part of the false lumen still remained, which is the same as here. And particularly if you look at location 1, location 2, and there's the agreement between this prediction with the modified model is very well, with the agreement is very good with the ground truth. But if you look at the details of the original model where I pointed out earlier that we had a pointed tip here in the false lumen, which never gets thrombosed. So that problem, after considering the thrombus breakdown, incorporated into the modified model, and this error had been eliminated. So that's what we get from. And the other difference between this modified model and the original model is that if we look at the thrombus volume prediction, then the modified model stabilizes much more quickly. So it reaches a steady state of the thrombus volume because the thrombus cannot continue to grow. It will grow at some point and then it will stop. So this one, the modified model, allows this to happen more quickly, more stable, whereas the original model, it will take much longer time to reach that state. Right, so I think at this point I wanted to acknowledge the contribution of some of my former students. So this top picture, that was taken before COVID, and that was my group members, and obviously everyone there graduated. This is Claudia. All the work, the original thrombosis model was attributed by her. She's very bright, very talented. She currently works in Australia now. So her work is then continued by Chloe, who was a fresh PhD student at the time. But then if you look at the later picture, Chloe graduated with PhD in her gown after the graduation ceremony. She's doing a postdoc in my group at the moment, studying pulmonary hypertension. Now, the modified thrombosis model, but Chloe further tested Claudia's original model and did some further validation. The latest student, Kai Hong, and he has just recently finished his PhD, defended his thesis about a month ago in the summer. And so he was one who introduced the new breakdown terms and produced the further validation work. And then as we're staying on these slides, I mentioned about the turbulence work, the nice video on turbulence kinetic energy. That was actually done by Emily. So she was a student at the time, but this is when she graduated. So she's currently an academic permanent lecturer in University of Manchester. Right, so that's probably an appropriate point for me to start introducing the next topic. So we got a clot formed in a location that is not desirable and that's causing problems, and we wanted to break down that clot by using drugs medically. So some of this background. This is so the clot, this type of clot can form in the arterial system. It can also form in the venous system. So in arteries, if it's formed in the cerebral arteries in the brain, then this can cause ischemic stroke. But if the clot forms in the venous system, we probably heard about deep vein thrombosis or pulmonary embolism, right? So deep vein thrombosis is a relatively common disease, and so again, if you have a deep vein thrombosis, then it is possible to treat it medically or through surgery. So here we focus a bit more on the thrombus that is formed in the cerebral arteries, and how to model the dissolution of this clot through the use of drugs. The drugs are known as thrombolytic drugs, agents. So typically, these are just some background. So the occlusions that cause ischemic stroke, and these are mainly occur in what is known as M1 and M2 segments of the middle cerebral artery. So if we just familiarize with some of these anatomy, these are the major vessels in the brain. So remember that the heart is somewhere here, and this is aortic arch. We've been looking at the aorta quite a lot in this region. So now we're going to move up, because one of these branch, or in fact the two of these, will feed into the blood vessels in the brain. And then we have these anterior cerebral arteries, middle cerebral arteries, and the internal carotid artery. So this is probably the area where the clot is likely to form. If a clot is formed here and block these blood vessels, then it can block the blood supply to the brain, to part of the brain tissue, and causing stroke. So this is just a cartoon showing this clot blocking the vessel, and these are the red blood cells, and these blue particles represent activated platelets, and these yellow strands correspond to fibrin. So these are the essential components. You need activated platelets to aggregate to form a clot, and then you also need this fibrin to stick and wrap all of these together to form a clot. Right, so where we are, the ischemic stroke thrombi, looking at the thrombi, the components I've said, it has platelets, so mainly activated platelets, and red blood cells, and fibrin, so these are the key components. But it also includes some other factors. And the other factors, we don't model them explicitly, but it does not mean that they do not participate in thrombolysis. So if someone is going to take this further, continue to work on the modeling, then you will probably need to consider the other factors. So far in our model, that because it's already quite complex, we just considered these components. Right, so treatment of ischemic stroke. Currently there are two standard treatments. One of these is through intravenous infusion of thrombolytic drugs, and typically this is this is commonly used, but it needs for this treatment to be effective, it has to be delivered within a very short time window. And the other method, which has emerged over the last 10 years especially, has become mature now, is mechanical thrombectomy, either with or without thrombolysis. So this cartoon shows the mechanical thrombectomy. So you put a device inside, and then you're trying to reach the clot, and then it forms like a net. So you have like a mesh structure, and which kind of catch the clot, and then as you pull the catheter back, that the clot will be pulled back. So physically, mechanically removing the clot. So this is one of the treatment. We're not going to model this case. So the mathematical model that I'm going to describe you now deals with chemical dissolution of the clot by using drugs. So this is the treatment through thrombolytics. Well, typically this is a fairly simple sort of outline of how this works. So the thrombolytic drugs is known as tissue plasminogen activator. There are different variants of the TPA, but for now we just call them TPA. So TPA can be delivered either through intravenous infusion or through local injection into the blood vessels. And then when the TPA reach the clot, and this happens. So what happens is that the TPA can, so let's start. So start from here. So this is tissue plasminogen activator. So TPA acts on plasminogen that is available in the body, in the blood, and it activates plasminogen to produce plasmin. And plasmin then acts on fibrin to, so it's like when plasmin act on the fibrin, it's like it can cut the fibrin into small pieces because the fibrin are these insoluble strands, right? So once they are cut into small pieces, and they can gradually turn into fibrin degradation product, and this becomes so that the clot is said to be dissolved. But the plasmin can also have other effects. So it can dissolve or break down, I would say break down fibrin, but it can also produce antiplasmin. So there's body-produced antiplasmin which can counteract the function of plasmin. So all of these factors need to be considered, and there is a series of chemical reactions coupled with transport that need to be modeled. So after the TPA reaches the clot, so it acts after this series of reactions. It basically breaks down. So you can see that this is just a cartoon break down the fibrin strands, and then so the contents are released, and then the flow is restored. That's how this works from a simplistic point of view. So, from a mathematical modeling point of view, this is obviously a very complex problem. So, we need to consider several factors, because the current standard treatment using intravenous drug infusion, so we need to consider circulating drug and the plasma proteins, and that involves a systemic pharmacokinetics and pharmacodynamics model. It's known as PK/PD model. Mathematically, it's not difficult to solve because these are ordinary differential equations. And so that provides the circulating drug and plasma protein concentrations that we can use when we develop these localized models. So the localized model need to consider blood flow in the cerebral vasculature, and it need to model the drug transport and within the vasculature. And we also have to deal with fibrinolysis. So fibrinolysis involves the series of chemical reactions of TPA acting on fibrin. So these interaction processes need to be considered. So obviously that if we can overcome this challenge and build a model, then a model can be used to examine the influence of treatment protocols. For example, the drug dosage and infusion duration. And we can also look at how realistic arterial geometries might affect the efficacy of the lysis, and also see how the clot properties might influence this process. So I'll just give you a brief overview of the models that we have developed. So that includes, so look at the circulating drug in the body, so the PK/PD model first. When you build a PK/PD model, this is basically a compartmental model, so you can divide the system into multiple compartments, and you regard the body as a well-mixed system. So in other words, you don't solve any three-dimensional equations, and you just need to have a system of ordinary differential equations. But that need to be sufficiently complex to cover the key fibrinolytic proteins. For instance, here that we have the drug is TPA, and we have plasminogen, plasmin, antiplasmin, and fibrinogen. So all these are essential components. And then as we model the systemic circulation, we also need to consider the source terms, for example, the natural production of the sum of the product by the body, and the natural clearance of the system through the body. And we consider the rate of infusion, so this is how the drug is infused. So this is obviously based on the drug trial. So the infusion protocol that we simulated in our model follows the FDA recommended drug protocol for treatment of stroke, and which involves 10% of the total dose being delivered through bolus injection and bolus infusion, and then there is a short interval, and then followed by continuous infusion of the rest of the dosage. Right, so now let's look at the localized 3D model. So localized 3D model, if we look at one of these bifurcation, This is the internal carotid bifurcation, where it has two branches, the anterior cerebral artery and the middle cerebral artery. And imagine that there is a clot sitting somewhere here. And so we need several equations to describe that. So the clot is modeled as a porous medium, and the rest is described by the Navier-Stokes equations. So you have the momentum source term for the porous medium. And so here we consider the blood flow and pressure. These are described by the mass conservation, momentum conservation, coupled with physiological boundary conditions. So these are fine. We've dealt with yesterday. And then we have the drug transport. So the drug transport, we can use the convection diffusion equations. All of these need to be solved together. Now, so in this process, when we model the clot as a porous medium, there is a permeability of the clot. So obviously, as the clot is dissolved, as chemical reaction takes place and chemical breakdown of the clot takes place, that the permeability of the clot also changes. So it becomes more permeable as it's dissolved. So the permeability of the clot, it varies as a function of time. So it depends on the volume fraction of the fibrin in the clot in the system. So the volume fraction of the fibrin is then resolved through solving a different set of equations, and it's also related to the initial fibrin size. So how is that? So it's further equations to show that how the fibrin volume fraction is worked out. The fibrin volume fraction is related to the initial fibrin volume fraction, and then multiplied by this term. Now this term we define the EL is the extent of lysis. So how much percentage of the clot is lysed, essentially, and that is related to the binding site concentration. So this is the current number binding site. This is initial binding site. Now, if all the clot is dissolved, then this binding site will be the same. And so that, if all the clot is dissolved, then there is no binding site left. So this n will become 0. So the extent of lysis will be 1. Okay. So now, looking at this equation, because these terms obviously is important, and these need to be solved. And how do we solve that? We need to look at the fibrinolytics. So looking closer into the clot. The fibrinolytics, this is quite a complex process. And so it involves a lot of these species that as shown there. So this yellow strand, and this basically is a cartoon representation of the fibrin strands. And the fibrin strands are quite important because they tie the blood cells together to form a stable clot. So the task of thrombolysis is basically just to break down the fibrin strands, and so that the blood cells trapped inside can be released. So these are the key parameters, the key players. So TPase, plasminogen, plasmin, and so each of these yellow blocks, they represent a free binding site. So initially that you have initial concentration of free binding site. Then all of these species will try to compete to occupy a space, and that will cause the reaction to take place, and then therefore the breakdown of the clot. Right. So this is not the whole set of equations, just a representative list of the equations. The key reaction equation for these, and these are the reaction rate for each of the reactions, and these are the number of species. These lists can go on. It depends on the drugs that you model and the complexity that you want to introduce. So basically, that the fibrinolytic reactions that involves absorption, desorption of the proteins, and then this is the enzymatic reaction is described using the Michaelis-Menten equation, and then this deactivation and degradation is also included in these reaction equations. And then so these reaction equations need to be solved together with the flow equation, together with the transport equation of the drug, and then the end product is reflected in the change in the binding site, and therefore the lysis extends and reflected in the momentum equation as a change in permeability through the clot, right? So I will probably not go through too much of the details here. Basically, this just says that the model also considered the microstructure of the fibrin, because you have to come up with estimation of the number of binding sites. And in order to calculate the binding site, you have to look at the microstructure of the fibrin, and the chemical reaction will decide how quickly that the binding site will degrade. Right, so let's look at some of the representative simulation results. So this, from lysis model, this was first developed by my PhD students and Andres Paibo. So he did his PhD thesis, and then this paper actually described the model and these results pretty well. So one of these models that he built was this bifurcation model that I mentioned earlier, and then there's a clot in there. And they modeled a commonly encountered MCA clot with different lengths, with different initial fibrin fiber radius. So this is start with 30 nanometer, and this represents a very fine clot. And then if the fibrin radius is approximated as 85 nanometer, this represents a coarse clot. So try different TPA doses, and all of these are recommended for patients, but the standard is probably 0.9 milligram per kilogram patient weight. So the blood flow is modeled with a given flow rate, and the protein concentrations included all of these, and these were obtained from the PK/PD compartmental models, and these fed into this model and then to get, so this is injection protocol, right? So let's see what the results look like. Now, so we've got a lot of the picture here. This shows the lysis pattern for a fine and a coarse clot. I'm just trying to figure out which one is fine, which one is right, so the fine clot is on the left and the coarse clot is on the right. So here you have the fine clot, and here you have the coarse clot. So this is what the flow field looked like initially. So you can see that this long clot is blocking the flow. And because the blockage, the initial resistance is very high, and so that the flow that enters into this bifurcation, they all get diverted through the open branch. So there's no flow that can permeate through the clot to reach the blocked vessel distally. Now, gradually, because the drug is carried inside, and then after some time, the TPA will reach the surface and then will act on the clots. So as the TPA breaks down the fibrin, and you can see something happen. So initially it's through the change in the permeability through the clot, and then at one point that there is a breakthrough. So this is when the clot, there is a breakthrough, so that you can see the flow can pass through. Initially, when there is a small breakthrough, that you have a high velocity jet, and then followed by these vortices behind. So the flow can become quite turbulent in this case. But then after that, you can see that the clot gets degraded, and then there is only a small part left to stick to the top wall. And then if you have sufficient drugs, and if you infuse the drug for sufficiently long time, then these clots will eventually degrade completely. And I think similarly that you have the figures for the same clot, but with different structures. So represent the coarse clot. The only difference is lysis pattern is similar. The only difference is that the time it takes for the clot to degrade for the coarse clot is much shorter compared to that of a fine clot. So here it plot the volume of the clot as a function of time as the clots degrade. So here is the start of the lysis, and then there is a rapid reduction of this is the lysis starts, and then so this shows how the clot volume reduces as a function of time, And then this is where the breakthrough takes place. So the blood flows start to pass through. And then eventually that the entire clot to get degraded after this many hours. So obviously this is quite a long period of time to get the clot to completely dissolve. But in reality, you probably don't need to dissolve the entire clot. The key is to ensure that the flow is restored. As long as the clot is dissolved sufficiently that to allow the flow to pass through, that's probably reached the aim. And likewise, you can see that for the coarse clot, the pattern actually quite different from that. Even though at the start of the lysis is probably similar as the fine clots, but it takes much shorter time for the clot to become completely dissolved. Right, then you can look at some further more complex, more realistic geometries. So this is a geometry reconstructed from CT scans. This is the internal carotid artery, and then we modeled the two bifurcations in this case. So one is the middle cerebral arteries, anterior cerebral arteries, and also the M1 and M2 segment. So the clot can block here. The clot can also happen here. So the intention was to try to see whether the lysis is different between the location of the clot. And if the clot is located in different segments of the vessels, does it affect the lysis? And we also created a different volume of the clot by changing the length of the clot as well. And this work has been reported as well. And just give you some snapshots of the results. So the flow obviously become very complicated, and this is the M1 occlusion, where the clot is situated in the first generation bifurcation over here. And this is what the flow pattern looks like as a function of time. And you can see that at some point that this is probably, this zoomed in picture shows the moment when the breakthrough starts, so that the permeability of the clot has increased sufficiently to allow the flow to pass through. And then you see that the jet of the flow come through here, and then after that, the clot starts to dissolve until it completely disappeared over time. And if you look at, if the clot is located somewhere over here in this junction rather than over there, this is what the flow pattern looks like. And again, this is how it evolves as a function of time. If you look at these zoomed in picture, and it shows the moment when the breakthrough takes place. Well, the interesting thing is that the breakthrough in this case takes place on the top of the clot rather than the bottom of the clot. So apparently the lysis pattern is influenced by the geometry of the vessel and the location of the clot. Right, this is some very exciting work that we did and published in Science and Advances a few years back. And this involves the use of targeted thrombolysis. So the work comprises two parts. I will not have time to go through these in great detail, but just give you some general ideas. So this work is in collaboration with my colleague, Professor Chen, in the same department. So he is the expert in nanotechnology, developing nanoparticles for targeted drug delivery. So we came together a few years back, and we had this idea about delivering using nanoparticle technology to deliver TPA into the clots. And again here, the motivation is that there are lots of limitations with the use of TPA type of drug for thrombolysis in patients, because TPA is known to cause bleeding in undesirable locations. And so in order to minimize the hemorrhage, so this is called cerebral hemorrhage. So in order to minimize this serious side effect, it would be desirable to be able to target the TPA to the clot only, so that the TPA will not be released in other part of the system. Right, so with that in mind, that a smart nanoparticle developed, and I'm not a nanoparticle expert, so I can't tell you exactly how it was synthesized, but it was designed to have these features so that TPA can be encapsulated inside these nanoparticles, And because that the clot has activated platelets, so that these nanoparticles been surface engineered to have these integrins. And then with these surface engineered particles, then these nanoparticles, once delivered into the system, and they will go to the clots, and they will bind to activated plate within the clot, and upon binding with activated platelets, the TPA encapsulated inside nanoparticle will be released. So this is a targeted delivery, targeted release of TPAs. So we model these. The model will include all the essential components that I mentioned earlier, but you have to introduce some additional equations. I don't think I've brought the equations over here, but if you wanted to know the details, there is a very long supplementary materials attached to this paper we published, which give you all the details of the equations that we used. The additional equation that we had to include that describe the nanoparticle transport. So you have additional set of equations that govern nanoparticle transport and also the release of TPA from nanoparticles. And there will be additional reaction equations describing the attachment of nanoparticles to activated platelet, etc. And in terms of the release mechanisms, and that's been calibrated using experimental data, because experiments being carried out using the nanoparticles at different concentrations of activated platelets. So you get these profiles, and then we can fit into these figures to get the actual release rate, which can be included in our model. Then we use the model to predict the experiment. So the experiment, in this case, the experiment was limited to this is a microfluidics experiment, so it didn't go into like animal studies or human studies. So we made use of the experiment performed in a microfluidic device and then simulated the experiment. But there are some uncertainties because to simulate thrombolysis, we need to know the initial condition pretty well. We need to know the initial clot properties, and that is a limitation here because in those experiments, the clot properties were not measured. So they just formed the clot and put the clot inside the microfluid device. So it's a bit of a guesswork. So we have to decide what kind of, is it a fine fibrin clot or coarse fibrin clot, because the lysis rate can be very different. But nevertheless, we were able to qualitatively reproduce the experimental findings with this nanoparticle delivery. And then we extended this work in trying to simulate different scenarios using this nanoparticle targeted delivery. And this is the advantage of having a computational model, because then you can have a list of the parameters that you think would be important. For example, you can change the clot properties, simulate different clot properties by performing numerical experiments, and then you can change the dosage of that. So we did this study. I think if we just look at on the right-hand side, these are summarize the key. So this is published in a separate paper. Summarize the key findings, and it's measured. So the efficacy of the lysis is measured by recanalization time. So the shorter, the better. And the TPA is the current standard treatment using the FDA-approved protocol. So this is the number of minutes required to dissolve a given clot using this standard treatment. And using the nanoparticles, and we found that the time is actually shorter for a specific type of the clot. I forgot exactly which one of this light shade. I think one of the shade is the coarse clot, and one of the shades represents light blue bars is the dense and the platelet-rich clot, and the dark blue bar correspond to the coarse clot. So it depends on the property and the type of the clot that this nanoparticle delivery can have a slightly different outcome. But the interesting thing is, we found that because the TPA is encapsulated inside the nanoparticles and they're only released at the clot site, we can actually use a much smaller dose. This is actually with the 10% of the standard TPA dose that we can achieve the same efficacy. So this is very promising. It means that if that is true, if this can be approved in animal or future human studies, then with the nanoparticle technology, we can not only target the delivery of the TPA, but also using a much smaller dose than a standard free drug delivery. Right, so then there are different types of thrombolytic drugs. Some of these are new, some of these old. So here, with a model that we can simulate the performance of different drugs. So alteplase is actually the standard TPA, FDA-approved drug used in the treatment of ischemic stroke. Then there are other drugs like the old ones, including urokinase, and then vectiplease. And tenecteplase is a new drug. And in fact, tenecteplase has only been approved early this year by FDA for treatment of stroke. So when we published this paper, and this has not been approved for clinical use just yet for treatment of stroke. So we simulated different drugs using the corresponding kinetics for each drugs. And we compared their performance in terms of lysis time, and also compared the systemic fibrinogen concentration, which is a marker for risk of bleeding. So in terms of the lysis performance, what we found is that the one that is the slowest is the vectiplease, and the lysis time, so urokinase is the fastest in terms of lysis, but it's only a few minutes faster compared to tenecteplase and alteplase. And in fact, tenecteplase and alteplase are very similar. But in terms of the fibrinogen concentration in the system, which marks which can be used to estimate the risk of bleeding, so the higher the better. And so the scenario you want to avoid is that the fibrinogen concentration in the system drop to a low level, because at a low level that the risk of bleeding is increased. So we look at the 4 different drugs actually perform quite differently. I think the best performer is this red one. The red one is actually tenecteplase. This is a new drug. So this is very good. And the blue one is the blue is alteplase. No, the alteplase is the orange ones. Sorry, I got it wrong. The blue one is tenecteplase, and the orange one is alteplase. So we can see that this new approved drug, tenecteplase, actually, in terms of the risk of bleeding, is probably better than alteplase. This one is urokinase. Obviously, this one has a high risk of bleeding, and so this drug is actually hard to use in treatment. Even though this one maintains the level of fibrinogen from this perspective, it has the least risk for bleeding, but it takes too long. So the kinetics is very slow. It takes the longest time to dissolve the clot. Interestingly, using our model, we can also simulate a cocktail of drugs by picking the best part of each drug and trying to mix them together to see how that performs. So we recently done a work, and that was published by my PhD student. So he's finishing his PhD later this year. So he used the standard alteplase TPA with a mutant type of urokinase and mix them together, and to see how mixed drugs can perform. So obviously the kinetics are quite different, so need to investigate the exact kinetics for each of these drugs and how they can complement each other when used together. So it's quite interesting that the combined drug can actually perform better with much lower dose of TPA in terms of the lysis performance efficacy. I think that probably summarizes the performance, and you can test that for different dosage and different type of the clots. So I made not go through too much of these details. So if you want to read that, it's all written in that paper. Right, just to summarize these, so I've shown you a multi-scale model for thrombolytic therapy in ischemic stroke. So the model can be applied to realistic arterial geometries, so it doesn't really matter where the blockage occurs, as long as we have the medical images that we can reconstruct the three-dimensional geometry. And in fact, in that space, the current work has been extended to include the entire cerebral vasculature in the brain. So the geometry is much more complex than the example that I showed you earlier. So we're still in the process of wrapping up that work and get it published. And I've shown you that the model has been used to predict the therapeutic outcome for different arterial geometries, and to show you how the clot location and clot properties might affect the lysis performance. And in order to help optimize the dosage, we've developed 1D model. So it's like a reduced order model of the same thing, because the three-dimensional model takes a long time to simulate. So we're not talking about a few hours. We're talking about sometimes a few weeks, even on a high-performance computer. So it is time-consuming. So we developed a 1D version of that, and to see to what extent that some of the key outcomes can be reproduced using a reduced order model. And also we've extended the model to simulate targeted delivery of using nanovesicles. So it's not limited to the specific liposome-based nanoparticles that I showed you, which we published. My colleagues, we're jointly developing new nanoparticles, so we continue to using the model to adapt to different type of nanoparticle for targeted delivery. And the model can be adapted to simulate different combination therapies, for example, different drugs, as I showed you. So eventually, we're hoping that we'll be able to continue to refine the model and validate the model. Validation is very important. It's not easy to validate this model. So I hope to collaborate with a team in the US where they can perform thrombolysis experiment under controlled condition. So under controlled condition is very important, because you know what you put in, and then so that your numerical model can be established to create it to reproduce exactly the condition of the experiment. And then you can compare the outcomes with the experimental results. And so in the end, we're hoping to be able to use these to perform some virtual clinical trials. So that is our end goal. I think with that, I'll finish today. That's quite a lot of things to take in. I'm happy to answer any questions.
Yeah.
Change the prediction of what? The last bit I didn't hear.
Of the model.
Change the prediction of the model? In which sense? Are you talking about the thrombolysis models? So can you be a little bit more specific? So how change the prediction of the model?
The tear in the previous model with the false lumen.
She was asking about the true lumen and false lumen.
Oh, no, it's not about the thrombolysis. Okay, the true lumen and false lumen. I see what you mean. So change the prediction of the model over time.
If the tear became bigger in the future, it may differ the result of the prediction.
Sorry, can somebody help me with that question?
So she is saying that there are tears between.
Oh, the tears.
Yeah.
Okay.
So when the flow becomes more accelerated, the velocity becomes
yes. I now understood your question. I think that's a very good question. In fact, yes, that's true. So the tears obviously is not fixed in size. So over time, over years, the tear can actually expand. So the model that we built was based on an initial geometry. And that was reconstructed from CT scan taken at a specific time point, right? So that's the starting point. And we modeled how the thrombus might form, but the geometry, the tear size didn't change, So I think in the future, it would be very interesting and challenging to actually to include the modeling of how the tear actually develop over time. Yeah, the tear size is not fixed. If you look at the CT scans, over time it can expand, and some new tears, the small tears, the re-entry tears, can actually form. Yeah.
So, in your models, you talked about the geometry of the aorta or other blood vessels, which could be imaged by MRI or CT scan.
Yeah.
But there are high chances in brain or other places where the clots could be formed in arterioles or vasculature, which can't be imaged by CT or MRI. So these models are only limited to the image, the parts which could be imaged and computationally modeled, right?
Yeah, that's a good question. So yes, exactly. For the aortic disease, the initial diagnosis include the CT scans, and then in some hospitals, MR imaging facilities available, so you can do MR as well. On the brain, it can be emergency, so you may not have CT scans available. So I think here the purpose is a bit different. So the purpose of modeling the aorta in the case of the aneurysm or dissection is to be able to hope that the model can help understand the performance of different treatments and also predict the outcomes. And then eventually it can be used as a surgical planning tool so that surgeons can, with the aid of the model, they can kind of project the outcome with different procedures, and they help them to choose the optimal surgical procedure for a given patient. But the purpose of developing the thrombolysis model is not to predict the outcome for individual patient. It's actually to build a realistic model to do it outside, and then try in different scenarios to see to optimize the dosage for different types of the clots. So the hope is that in the future, if there is a technology that allows us to estimate the type of the clot of the patient, and then if we also accumulate sufficient knowledge that a different dosage or different drugs might perform differently for different types of the clots, then you can probably match the type of the clot with the optimal type of the drug. If you see what I mean, yeah.
Any other questions? If there are no questions, thank you all. We'll have the next day's lecture at 10 o'clock tomorrow. Thank you once again. And thank you, Professor Moon.